Good morning and good evening. Welcome to episode 42 of the Asia Society Hong Kong's COVID update series. I can't believe it's episode 42. When we started in February of 2020, we thought it was going to be a short series, but 42, almost 2.5 years later, we are episode 42, and we're really delighted today that I will be speaking with Dean Michelle Williams, Dean of the Faculty, Harvard T.H. Chan School of Public Health. I know some of you may know there is kind of a connection with T.H. Chan School of Public Health in that both we are really recipients. Ronnie, our chairman, and his brother Gerald have been a supporter of Asia Society Hong Kong, but also those of you may know in 2014, a historical donation of 350 million was made in one of the largest in Harvard history at the time from Morningside Foundation, and it became the T.H. Chan School of Public Health. Mr. T.H. Chan is the father of Gerald Chan and Ronnie Chan, so we're really delighted at the connection, and we're really delighted that today, episode 42, Dean Williams have joined us this morning from Boston to talk about health disparity. I think with we've talked about for this COVID series, we've talked about vaccines, we've talked about a lot of issues, vaccination, quarantine, all sorts of things, but we haven't really focused that much on health disparity. So this morning, we're going to be speaking with Dean Williams on this topic. I think you will see her bio, a very distinguished bio in our website, so I won't repeat it. And but she became the dean of T.H. Chan School of Public Health in 2009, I believe. Sorry. 2016.
16.
Yes, I'm sorry, 2000. And I think the School of Health is currently ranked as one of the best schools for public health in the world by the academic ranking of World University, and is also ranked as one of the third best public health school in the nation by the U.S. News and World Report. So we really have an expert here to talk about public health and the disparities. And with all the stuff that we're hearing online these days, besides COVID, I think lately with the monkeypox and others, health disparity is still an issue. So we are very, I'm really looking forward to my discussion today with Dean Williams. So let me start off by asking Dean Williams to talk about briefly, her thoughts on this issue and what has she been doing in terms of this last 3 years. When you became dean in 2016, I think the last thing you probably expected was a global pandemic that have lasting over. It's going to be coming up on 3 years. So, yeah. Dean Williams, I'm going to hand it over to you to give us kind of your overview on this topic, and also what have you been doing recently in this area?
Yeah, thank you. Thank you, Alice. First, let me thank you for the invitation to speak today. And I'd like to add my good morning and good evening greetings to your viewers. You and your guests really have been involved in a wonderful series that have covered a wide range of the topics around the COVID-19 pandemic with a comprehensive depth and candor. So it's a real honor for me, and I really appreciate the invitation that you've given me to talk about what is at the heart of the academic work that we do in public health. And that is to look at with open eyes and clarity where we have seen disparities and we have seen excess burden of the impacts of COVID-19 on specific populations as they relate to race, ethnicity, and gender. So thank you again for the opportunity to speak. And what I'd really like to do as an academic leader of public health here at the Harvard T.H. Chan School of Public Health is share with you our observations, what we have learned, and what are the steps we're taking as leaders in academic public health to engage in addressing health inequalities. First of all, let me say that we have seen this pandemic, in particular COVID-19, surfacing longstanding inequities that have been even expanded as a result of the pandemic. We have seen millions of people caught up in this painful reality of a health shock like a pandemic contributing to worsening health statistics. I'd like to use my opening remarks to address the situation in two parts. First, I'd like to consider the outsized impact the pandemic had on people of color and ethnic minorities. And then I'd like to touch on how the pandemic set back the health and wellness and livelihood of girls and women in the US and globally. So I'll speak about disparity from a racial ethnic perspective and then also from a gender perspective. And first, I want to say, while I believe it's vital that we are clear-eyed about the pain and losses experienced individually and societally because of health disparities, I want to also focus on what is happening on the ground in communities, in nations, and across nations and regions to make positive change in this space of health equity. All right, so let me first start by saying something about racial and ethnic disparities. Early in the pandemic, it became clear that people from racial and ethnic minorities were more at risk of getting sick and dying as a result of COVID. To date, we have seen that Black and Hispanic people in the US have experienced a staggering 3-year downturn in life expectancy compared to the 1.2-year downturn for white Americans. These are data recently reported by the National Center for Health Statistics. What these data tell us is that overall, every community, every racial ethnic group experienced a downturn, but racial ethnic minorities experienced more than double a loss in life expectancy than their white counterparts. The reasons for this very important dramatic statistical differences are straightforward in some ways and very interrelated and complex in other ways. For example, scientific data shows that Black and Hispanics and Indigenous Native people were more likely to contract the virus than their white counterparts, and they were more likely to be hospitalized and die as a result of the infection. These facts explained why early on in the pandemic, Black, Hispanic, and Indigenous people made up more than 60% of COVID-19 deaths, while making up only 32% of the US population. Let me talk about the complexities behind these statistics. The complexities come down to the conditions, the unequal conditions that promote health and wellness in populations writ large. The complex reasons are specifically related to the fact that the social determinants that drive the root cause of health, wellness, and resilience to shocks, like a pandemic, are unevenly distributed across racial and ethnic groups. When I speak about social determinants of health, I am speaking about those upstream factors, upstream from the medical infrastructure, that drive health, wellness, and resilience to shocks. These conditions, these determinants are, where people live, learn, work, and access healthcare. These social determinants are important in underlying the health and resilience of populations. For instance, when the COVID-19 vaccine became available, access to the vaccines, access to this public good for life protection, life promoting interventions, those vaccines were less likely to be distributed to healthcare facilities in communities with a high proportion of Black, Hispanic, and Indigenous residents. So those people who were more at risk of contracting and dying from this pathogen were least likely to have equal access to the vaccines compared to their white counterparts. Furthermore, vaccine hesitancy, even when vaccines were available, vaccine hesitancy although it was an overall concern for all Americans, very prevalent, the concern was particularly acute in Black and Indigenous people in the US. This was related to historical traumas experienced by these particular communities. A history of medical and government exploitation of these populations and the legacy of that exploitation contributed to developing a trust gap. And that trust gap led to higher anti-vaccine beliefs among minorities. So really remote from the actual pathogen and medical response are these social and historical factors that drive the disparity. Also, in the US, we talk a lot about the legacy of structural racism, the history of anti-Black racism, for example, that has led to housing insecurity, poor housing quality, disadvantaged access to educational and employment opportunities. All of these social determinants underlie the contribute to that higher burden of disease and higher risk of dying from COVID that we've seen in our country, and especially acute since the pandemic. I'd like to now quickly turn my attention to speaking about structural racism and how the pandemic amplified awareness and motivated action at a public health level. Prior to the pandemic, we started to hear advocates, community leaders talk about racism, structural racism in particular, as a public health issue. The pandemic really surfaced racism as a driving force of social determinants and how these social determinants, when not provided equitably in communities, leave communities vulnerable. For example, we in public health at Harvard and across the country were very attentive to the testimony that was given to the US House of Representatives by an NGO, a non-government organization called the Human Rights Watch. The Human Rights Watch argued that ongoing racial disparities reflect failures at every level of the US government to protect the human rights of ethnic and racial minorities. The Human Rights Watch further argued that government policies over generation have created these racial disparities across multiple systems: health, education, housing, and criminal justice, for example. And when we think about public health, and especially as we look at this global public health crisis in a holistic way, we can see that the importance of this testimony, that social determinants, factors way upstream from the biomedical infrastructure, housing, education, social justice, all contribute to the resiliency or the vulnerability of communities based on the inequitable distribution of these factors that are important drivers of health. There's also a large literature, a lot of it contributed by our faculty at the Harvard Chan School, but many others that show that individual level psychosocial stress, secondary to living in inequitable in society, particularly where there is bigotry and prejudice, leads to repeated measurable impacts on health and longevity. And these impacts contribute to higher rates of disease. This is important because we saw that individuals with pre-existing diseases and conditions like asthma, diabetes, heart disease, we saw that these individuals with pre-existing conditions, COVID made their health factors even more perilous. An example I want to share with you is a recent poll conducted by my colleagues at the Harvard Chan School of Public Health and collaborators showed that 35% of Native Americans and Native Alaskan households and 24% of Black households had trouble accessing care for serious illness during the pandemic. And that's compared to 18% of white households. Now, even the 18% in the US is far too high to have limited access to healthcare in a pandemic, but that the access was even more limited for the most vulnerable populations in the country speaks to the importance of addressing health inequality by race and racism, by race and ethnicity. One last statistics I'll share in this part of my remarks is that we are now seeing that suicide, a very important determinant of mortality, is also a growing crisis for communities of color. Rates of suicide for Black, Hispanic, and Asian Americans are increasing, and increasing at an alarming rate. We're also seeing massive increases in young people of color, particularly Black children under the age of 12, who where their suicide rates are now twice as high as their white counterparts of similar age. So, you know, I don't want to share these statistics and reflect that it's only gloom and doom. I do know, and I do want to be clear-eyed, that these are heartbreaking statistics, Alice. But I also want to turn briefly to where I think there are opportunities for a mindset shift so that we can address these disparities. First, we must address the entrenched, structurally connected inequities that I have described, because these inequities are the root cause of health disparities. We have to address food, housing insecurity, and we have to ensure adequate living wages for better working conditions for essential workers. We also have to be sure that we are attentive to doing the surveillance and making sure quality health care and quality access to life-saving interventions like vaccines reach those populations that are the most vulnerable. We also have to stay alert. We have to really be attentive to the racial disparities that emerge as we address other pandemics or public health threats. And I want to add, I know this is a conversation about COVID-19, but we're now in the US and globally struggling with the emergence of monkeypox. And I want to say, despite what we have learned as we grapple with COVID-19, we are seeing some of the same missteps happen as we respond to to monkeypox outbreak in the United States. For instance, data coming in from North Carolina shows that 70% of the monkeypox cases are diagnosed among African American Black men, but only 24% of the vaccines have gone to this group. 70% burden, 24% of the life-saving intervention vaccines are getting to this population. By contrast, 67% of vaccines have gone to white recipients, although only 19% of the cases are diagnosed among white men. This is a potent and heartbreaking example. And I say that because even in the wake of COVID-19 pandemic, we are seeing these disparities in response to a health threat play out again. Lessons have to be learned and systems have to be put in place to be sure we're not expanding disparities, but we're actually mitigating them. There are examples that I briefly want to share with you. Public health leaders, not universally, but increasingly, are working to tackle the impacts of racism at multiple levels. For example, in Massachusetts, the home state where the Harvard Chan School is, we are working with local community health directors and civic leaders on bold projects to address health inequality in Massachusetts. And it's a statewide effort that involves public, private, and academic partners committed to supporting research, translation of those research findings to support the implementation of evidence-based interventions that then promote health equity and health overall in the community. We're also seeing a national response, and we're seeing, I want to give an example that is very encouraging to me. Recently, the American Medical Association adopted a resolution that has been co-sponsored by the National Medical Association. And this resolution is calling out voting rights. I mean, some people would say, what does voting rights have to do with public health? But here we have the American Medical Association and the National Medical Association calling out voting rights as an important social determinant of health. The scientific logic of this is clear. Political maneuvers like gerrymandering in the United States limit access to care and leads to environmental and social conditions that drive the worsening of health outcomes. And so these movements are really critical for us to understand that health and wellness is embedded, yes, in the biomedical system, but the determinants are way upstream that involve these social, political, and even historical constructs. And then additionally, I want to say at Harvard, especially at the Harvard T.H. Chan School of Public Health, we recognize that we have to be even more intentional, more deliberate, more strategic in partnering across sectors. So recently, at the last year, actually, in November, at the Bill and Melinda Gates Foundation Grand Challenge convening, which was held virtually, I coined the term, we have to create public, private, and academic partnerships. And I do that because, we talk about PPPs, public-private partnerships. And there are evidence of success of these partnerships working, but they're not always transformative. They have been one-off partnerships. My argument is when we come together as public-private academic partners to address hard, complex problems that require a sustained, transformative approach to solution development and implementation, by working together in this multifaceted way, we can create the space that is integral for promoting and sustaining positive health change for local and global health circumstances. And I'll give you an example. We, early in the pandemic, saw that there were leadership gaps in the coordinating of public, private, and academic entities in the response to COVID. So we created a partnership called COVID Collaborative. This was a diverse team of experts in health, education, and economic leaders. We had members from Fortune 500 companies, we had academic leaders from across the nation, and we had civil servants all engaged. And one of the things that I'm really proud of that this partnership did, and we did many things, but when the vaccine became available, the partnership decided that we had to take on, in a very robust way, the vaccine hesitancy issue. So we teamed up with the Ad Council. Now, many people in academic public health might not be thinking about the Ad Council in their everyday work, but the Ad Council led to the creation of a massive, effective communication effort that led to increasing vaccine acceptance in the US, especially in minority populations. Now, for those of you who are old enough to remember when the polio vaccine came out 70 years ago, it was the Ad Council that really contributed to addressing vaccine hesitancy. So I was really proud of the fact that this public-private academic partnership really committed ourselves to engaging in powerful ways. We're also promoting this concept in terms of the global response to vaccine manufacturing inequity. So in working with our partners at the World Bank, at Harvard, at the Institut Pasteur in Dakar, we are driving the agenda, promoting this concept of our coming together and working in respectful partnerships with members in the Global South and the Global North across all sectors to really think about bringing the best of science, the best of technology forward in an equitable way, domestically in the US, but also globally. So Alice, I could stop there in my remarks. I haven't gotten to the gender inequalities, but I just wanted to check in with you.
Well, I wanted to thank you for that opening remark. But what you said about the ad council just reminded me because I'm in the US right now visiting my family. And just the other night, seeing a very powerful ad targeted at the minority group. And I was wondering about that because compared to a year ago,
Yeah.
one thing that I've noticed from a year ago now and this year and last year, day and night. And some of the ads, and I was like, wow, that's a very powerful ad. And I wonder what ad, who did it. So you answer
Yeah.
my question in that. I think what you have addressed is something that I kind of want to use this program. In the beginning, we've talked about more of the day-to-day COVID development, but as the program have evolved, it really is about lessons learned. And I think what
Yes.
you're talking about in terms of the public, private, and academic collaboration. This is an area maybe I can also ask you a little bit about. When last time I spoke to you online or saw you online was with this program, the collaboration, the MOU that Harvard signed with Dr. Margaret Chen, who was
Yes.
representing as Dean of Public Health for the Tsinghua Vanke School of Public
Yes.
Health. This was just a few months ago. So that academic component to it that you mentioned, and also kind of the globalness, some of the disparity you talked about are more, really is about the U.S., the minority, the disparity. But we also see the disparity kind of showing up on the global level
Yes.
with countries in Africa or the developing countries. So can you talk a little bit, address a little about some of that issue of the disparities on the global level? I think you touch upon it a little bit with a vaccine,
Yes.
and maybe
Yes.
there is also a gender disparity issue there as well that I remember
Yes.
you spoke about very eloquently with Dr. Chen a few months ago.
Yes. Thank you for that. You know, Dr. Margaret Chan and I, in our roles as academic leader, and of course her role as former Director General of the WHO, we meet monthly and we talk a lot about what are the roles and where are the gaps that academic public health leaders can play in a crisis like this. And one of the areas that we saw unfolding where our voices could have an outsized impact is to bring attention to the fact that this is a global health and a global health security crisis. And this is the time for us to come closer together and to work collaboratively because of the risk of global inequities, particularly in our response to the pandemic. So with Margaret, we formed a formal MOU and we created a coalition of deans of schools of global health so we could come together, share observations, share best practices that were dynamically coming forward, and be intentional in being sure that we were sharing them with our colleagues in the global north as well as the global south. Specifically in the case of vaccine manufacturing equity, we saw that the conversation was becoming more hyper-political and less about the principles and core values of public health and global health as a human right for all. And we saw examples where global health diplomacy was not being practiced in the way that we all aspire global health diplomacy to occur. So we came together and we used our relative expertise, our respective expertise, to make a case for really pulling together in a collaborative way, public, private, and academic partners to address key problems. For example, we saw that India has the capacity to develop vaccines for their nation and for the globe, right? They're one of the biggest vaccine manufacturers. But diplomatic relationships fell to the side as countries that could supply the raw materials for creating vaccines closed off access to those raw materials. In a global health crisis where we're all interconnected, that failure to recognize the importance of a distributed vaccine manufacturing operation threatens all of us. So that's one of the concrete examples where it's important. The other thing we have learned is, while the diseases and the threats and the risks are distributed across the globe, access to tools and know-how are not. And so we really need to collectively improve nations and global access to a response, because we're all connected. The WHO, for example, responded in a very positive way around talking about low technology risk mitigating behaviors and practices in an effective way. And some countries were able to keep the surge of infections and the mortality rate down. But we in the United States hyper-politicized the response, and that really damaged us. And it helped to have global academic partners lend their voice to what was working and what was not working.
Now, I would like to really kind of talk about. I mean, one of the things that you brought up, I found fascinating, is really this the PPA, the public-private and academic. I mean, that is really because during this pandemic, I mean, I don't know how often I consult the THN School of Public Health for information, Bloomberg's Public Health, and Hopkins. I mean, the academic institutions, especially the public health institutions, have wonderful. I mean, you train, global expert, healthcare, public health officials, as well as doctors and so on. So I find the academic institutions, the information, and same thing here in Hong Kong. For me, it was talking to the experts at the universities, whether it's Hong Kong U, Chinese U, the various universities, is really get to the source of these scientists. But I think right now, one of the things that I wanted to kind of address now is really kind of this, especially the recent announcement by CDC, the reorg. Obviously, some of the institutions, maybe not the academic institutions. I think the academic institutions maybe are now more, used to the public-private partnership. But we're talking about the CDC or WHO, where sometimes it is still kind of silo-ish, and more, especially, I think in our previous conversation, you mentioned CDC. Sometimes one of the criticism was more worried about publication rather than action. And Dr. Walensky in her announcement is talking about, some of the reorg is talking about public health for action. So can you talk a bit about that, the CDC announcement, and also talk about whether WHO has done something right, but what are some of the deficits in some of these institutions? What areas can be improved? I know we here in Hong Kong and in Asia can learn from in terms of the communication and the involvement, the developments, lessons learned from COVID.
Yeah, that's that. Alice, thank you for that. You've given me an opportunity to talk about a couple of things. Let me first start to say something about Dr. Walensky's announcement last week about the need to reorganize the CDC. There are really amazing scholars and scientists who work at the CDC, many of them trained at schools of public health, of course, and have been recruited from schools of public health. But what Dr. Walensky shared, is that having taken a clear-eyed view of how the CDC has responded to the COVID-19 pandemic, and now how it's responding to the monkeypox outbreak, she and the reviewers of the CDC have recognized that there is a misplacement of emphasis in the CDC. Her comments about, the CDC having a tendency to be more academic than practitioners is very clear. The CDC had developed a mindset of really being rigorous and robust, which we always need, but doing so in a way that is slow and not nimble enough to address to an emerging public health response. And so the culture had been more around, iterative processes of getting data and getting data right. That takes time, and it must take time. That's what we in the academy do when we're doing knowledge generation and we're replicating and repeating. But in the time of a crisis, public health workers have to use the data available and make decisions in real time. So that's part of her point. The point she made about data also relates to the fact that we in the United States, we don't have a well-coordinated surveillance system that allows the CDC to really make decisions quickly. So the reorganization is involving two things: a data infrastructure that provides clean, reliable, comprehensive data at population levels, community, region, and national, so that recommendations and guidelines can be built, but also a mindset shift that the CDC's primary role is not to add to the academic literature, but to use the academic literature in key ways. The other thing that I find very remarkable about Dr. Walensky's remarks, and this is incredibly important because it relates to how effective are we, particularly the CDC, the FDA, and WHO, in communicating in basic, actionable language what the threats are and what the responses should be. And we've all failed in that in certain degrees. So Dr. Walensky has recognized that the CDC has to increase its capacity for effectively communicating health threats and health response and guidelines to people. Something unique happened in this COVID-19 pandemic that I have to speak to, and that is the hyper-partisanship and the misinformation that was particularly brought forward, by former President Trump, created very complex situations for our health experts to get actionable, consistent message across. And so we have to recognize that as we think about what's gone wrong, there are a couple of factors that were outside of the specific health system. Public health messaging in the US lacked urgency, and scientific experts were sidelined. And we saw that with Dr. Anthony Fauci becoming instrumentalized as a partisan voice as opposed to an expert voice speaking on behalf of the national public health system. The other thing about the reorganization, and I'll just offer this as a lesson that we've learned. We've learned that the COVID tests that we needed early on for diagnosis and for screening were far too difficult to access by Americans, and that CDC should not have tried to design or test their own virus. This is a lesson they should have learned, and we should all learn, because WHO did it right. WHO went behind and supported the use of the German developed test. And that really solved a lot of problems and got a robust, reliable test out into the hands of nations and communities within nations to address. So the CDC's role in this is outside of its real domain of expertise, and it caused some problems. One thing I'll also say is government agencies, as well as international authorities like the WHO, really did issue very early on confusing information about mask wearing. And that is a lesson we have to learn. Science and information is dynamic, especially when we're dealing with a novel pathogen, a novel threat. And this is why communication, thoughtful, careful communication at local, national, regional, and global levels have to be thoughtfully, carefully designed and distributed in this context of uncertainty and rapid development of information that has to be shared. And sometimes, guidelines will be updated. We have to be clear why the guidelines are updated. We should not assume that the population we're serving can't understand why guidelines might change. I'll give you an example, Alice, and then I'll stop. The US initially at some point understood that mask wearing was important, but they muddled the response, the information they gave the general public, because they were concerned that if the general public started to acquire masks to protect themselves, there would be a run on masks, and healthcare, frontline healthcare workers would not have access to masks. The intention was good, but the way we went about it caused multiple months, if not years, of difficulties in communicating messages that Americans could believe and respond to. These are the things the CDC will have to work with.
I think when you're talking about this reminded me, episode 39, we had Mr. Tim Nguyen from WHO. Episode 39 was infodemics, and that how much information was out there for the public. It's confusing enough as it is. And then for the politicizations and also too much information. But then some countries or some institutions seems to have done better in terms of communicating. And I have to say, some of the professors that we feature on this program, Professor Ben Cowling, some of the professors at Hong Kong U, they became very effective in terms of using Twitter to get the information out. And I know they have many thousands follower because of the confusing information landscape, especially with social media. And it was just, we allow the access. I think some of the lessons learned, and even Dr. Fauci, who has been really good on TV, but sometime in this day of social media, I think Tim and I talked about infodemic. So I think if we have an opportunity, and I'm sure many of Harvard T.H. Chan School of Public Health and other schools, in terms of communicating in this time of pandemic, and it's now we're also hearing it with monkeypox, as you said. That information disparity. The minorities are not getting the information, even if you set up a vaccine center in Harlem. My understanding in reading the stories is that it's still the white person getting the vaccines in Harlem because it's not filtrating into the minority population that you, even though you, and also vaccine, another thing that Hong Kong has done we've done it well. In the beginning, we thought it's good intention is that everybody come and get your vaccine. But, I think you mentioned it too in the mask episode, although the intention is good, but not everybody access information the same way. I think all you have to do is you have demographics of the young people at home. TikTok is a better tool nowadays than for some of the old people like who are still using Facebook. So I think that was another topic we touched upon. But now I guess I want to really ask you in some ways. We have about another 15 minutes or so, and we do also have some questions from the audience from Slido. But I have so many other questions to ask you. But one of the things I really do also want to talk about and is really some of your as the dean of the TH School of Public Health, what are your priorities right now? And you're training public health for not just the United States, but the global community. What are after let's say 3 years? We're already 2.5 years. It's going to come up 3 years pretty soon. And you mentioned previously when we talked, you have been attending conferences. You've been traveling internationally now this year. And, kind of the importance of this global collaboration, these in-person meetings and conferences that you yourself have attended. Can you kind of talk about that so that here in Hong Kong, we're grappling with, we're still not quite open, 3-day change. Things have changed. It's better now, 3+4. But you were just recently in Singapore attending a major global public health conference. Kind of share with us what you have seen this year in terms of how things have changed in terms of opening up, sharing information in an in-person conference sort of way. So.
Thanks for those questions. They're really wonderful. I'm going to start with priorities for the school. I have the good fortune. I'm really closing in on 40 years of connection to the Harvard T.H. Chan School of Public Health. I was a student there. I was a department chair, and now I'm dean of this wondrous, great school. The school, has always been global facing. In fact, the first international students that we enrolled in our program in our school were 3 physicians from mainland China who went on, to contribute to the creation, the bedrock of global public health. So my aspiration for the school, which, when I became dean, I realized the school is a crown jewel within the whole ecosystem of the Harvard University system, the University of Universities. And so our aspirations are to continue to be that school where talented people who are guided by the principles and the desires for improving health and equity for all come and get the skills and training. My overall aspiration is that we train and equip the best public health professionals who can integrate across the full spectrum of discovery science to implementation to practice and policy. And I'm proud to say that we saw evidence of that full breadth and depth of experience in training and positioning leaders in that space. Now, I recently traveled to Heidelberg for the celebration of a Global Health Institute that just turned 60 years old. And right after that, I traveled to Singapore for the Global Health Security Summit. And in both of these experiences, they were my first international trips post the outbreak of COVID. And in both of these, we recognized and learned that by implementing those safety protocols that we were all designing, grappling with, that we could all come together. In the Singapore meeting, for example, by implementing all of the pre-testing and discussions about mask wearing and distancing where we were in small spaces, we were able to have a conference that had easily 1,500 participants from around the world come together and talk about climate change and pandemic in the context of global health security. For me, this created the opportunity to see on scale how Singapore, as the host, country, could support nationals coming from all across the world, Asia, Africa, lots of representation from Africa, Central and South America, and the United States and Europe, to come together to talk about collectively a global health response to health security threats. I would say that we've learned to use the tools that we have available to us to convene, to travel and to convene safely. I also will say we academics and public health leaders have missed out on the opportunity for real in-person engagements that we need to undergird the development of the kinds of collaborations and commitment to global health diplomacy, to sharing knowledge, to creating these public-private partnerships as necessary. In the meeting in Singapore, it was very informative to have public health leaders and public health academics. So we had ministers of health, the prime minister involved in the conference, but we also had academic entities, NUS, co-hosted the event. So for me, this was really eye-opening and a case study, very tangible case study that we can, using the right precautions and encouraging compliance to these precautions, convene safely, again, to address public health and global health issues.
It's interesting that this major conference you were talking about took place in Singapore, in Asia, and not in the United States or Europe. And that just shows, I think some parts of Asia are back. And although some places are not, I'm hoping in Hong Kong, in the near future, we will be able to host conferences like this, because I think, as you know, Hong Kong, it's not surprising when you mention the students, the early students at Harvard trained that were from China, because I think 1894, Yeltsin was here, plague was discovered here. I think there were a lot of, and the Hong Kong youth, Pasteur Institute has a branch here. So Hong Kong has been this place of where have experts in this area, and whether with SARS and now COVID. So I really do think Hong Kong has a role to play. And I understand from you, there were also Hong Kong officials, academics
Absolutely.
at the conference. So it really, again, the importance of this in-person learning. But what some of the, I think we only have 10 minutes left. I have had so much more questions. I think most of the questions from Slido about the disparity questions and health consequences you've already addressed. But one of the things, I guess, one question that I wanted to pose from the audience is, do you think the COVID pandemic has improved or worsened vaccine uptake among children generally? What is likelihood of a large polio outbreak in New York City? So this is questions, yeah, very, very topical right now here in New York. There's been talk of the polio resurfacing, but can you kind of talk about also the fears now of children's vaccination? We've talked about a minority, but let's talk about that, the vaccination with children.
Yeah, that's a very important question. And let me just briefly say, just to anchor some points here. First and foremost, the concerns about vaccine hesitancy and concerns about vaccine overall predates COVID. And I want to remind your audience that we in the United States and in other parts of the world were grappling with vaccine hesitancy for childhood diseases, even before the pandemic. In fact, in the United States, in certain communities, we were seeing outbreaks of measles, and so I think that we've always had this baseline ebb of concern about childhood vaccines that were in part driven by misinformation and disinformation, but also because of a decay in the health literacy. There were parents who are now having children who don't really understand that the small risks associated with vaccines, are childhood vaccines in particular, are far outweighed by the health risks of not being vaccinated by these diseases like mumps and measles and rubella. So what COVID did was actually help us increase the literacy among populations, if we were communicating effectively, the risk benefit of vaccines, especially for children, but for everyone, that the trade-off between getting a vaccine preventable disease and the small, very small risks of adverse effects for a vaccine have to be put in context. So the answer is a complicated one, yes and no. COVID did help us illustrate and demonstrate the importance of vaccines in health writ large. It did help us as public health people recognize that we have a lot of work to do in building that literacy, building trust, and working not in a one-size-fits-all message, but really speak to people where they are. Build the trust and design the message so that people hear it. And Alice, as you said, the message can't just be designed and delivered to middle-class, middle-income people. We have to use different modalities to reach ethnic minorities and young people. We have to design our messages around vaccine and all other health interventions with the intentionality that people are getting information from different ways. The other thing I will say is, though, what we are seeing now is not vaccine hesitancy, but a little bit of a burnout. I think people are saying, you said we needed a vaccine, then we got a booster, and now we're getting another booster, and we're getting this comes back to the basic message that we are learning and we are evolving. Scientists know this. We know that knowledge is iterative and that iteration allows us to build tools and responses. So there is a little bit of a burnout here, and we are seeing a reduction in uptakes of the boosters, but we have to address this because as the virus evolves, we have to design vaccines that protect us from those variants that break out of the immunity that we have protection for so far. So the answer is really complicated. I won't go on anymore, but it's yes and no. And we have to do more work and we have to be mindful. These vaccines, one of the things that worked well was that we created effective vaccines in a very short time, record-breaking time. Where we need to do more work in COVID for monkeypox and other childhood and vaccine preventable diseases is communicate very carefully, candidly, and precisely the cost benefit of vaccines versus not.
You mentioned, I think, the boosters. I don't know if you have any insight on the one that is coming out that's targeting Omicron. That my understanding is, I guess, next month in the United States, there's a possibility. UK has already announced that particular vaccination. Any insights on the latest vaccination? Even though you're right, it is, we're all tired of it, but with this evolving virus, the new vaccine, when is it, and are we?
Yeah. I hear that it will be coming out anytime now in the US. I'm eager personally to have access, because I think the protection of the vaccine and the public health interventions and protocols we've been talking about have allowed us all to gradually open up with some additional precautions. So I'm looking forward to it, because I think if we can have boosters that are addressing the variants that are emerging, it will allow us to continue on this steady path of opening up and fully engaging in society again. The vaccine alone won't be the answer. It's the vaccines, are taking those vaccines, are having access to antiviral medications now, which is really important, and then are continuing to be mindful about ventilation, about sanitation, keeping our surfaces clean, and really being mindful about continuing to wear masks in conditions and settings where ventilation and crowds are gathering. So I'm hopeful, I'm looking forward to it. I also want to encourage people, your audience are very sophisticated, but we know that one thing we learned was if we practice some of those public health mitigation processes, we actually decrease the burden and the impact of annual flu on our health. And so I'm optimistic, Alice, that with the lessons learned and the vaccines that are coming forward, that we will be able to continue on this pathway of opening up. One thing I want to say, though, is our governments have to continue to be mindful that subsidizing the vaccines are going to be important. Because if they don't make the vaccines equitable and affordable, available and affordable for all, we are going to have a worsening of the disparities.
So we only have 2 minutes left, and I wanted to wrap up, but I want to end with your personal story, because I have to say, for this series, I have been, my colleague and I have really wanted to talk to women, public health officials, women physicians, and women scientists. And I have to say, it's been challenging. In the episode 42 I think we've done maybe 5 women. We've been able to speak to 5 great women scientists and officials on this topic. And I would love to have, if not equal, more than 5. And you, as a African-American woman in your field, like you said, 40 years, what a career. And I guess I wanted to hear about your, I know, in fact, we can do another program just about that, because I think we need to hear from people like, you as an African-American woman in this field, what led you there? But then what inspired you? And also, how can you inspire? You are inspiring other minorities and women to go into the field. And I know Dr. Fauci, in his talk about his retirement, says he's going to write a book, and he hopes to encourage young people to go back into public service, or go into public service. And we know in this time, what we've seen this last couple of years, young people in public service is definitely needed. But not just young people. I'm talking about diversity. I'm talking about gender diversity as well, kind of how we started this conversation, and racial diversity. But how do you see your role in this very important field? And what is your advice to young people like you, who looks like you, who want to get into this very, very still kind of male dominant and white field? So what is your advice to those people?
I'm going to say, yesterday I welcomed over 350 of the 450 students who are starting their degree programs here at the Harvard T.H. Chan School of Public Health. And I'm getting teary as I think about, my engagement with these students. I admire and I respect and I am devoted to helping these new cohorts of students who come to public health to be as successful as they can be, because all of us are going to be dependent on them. They are going to be the next leaders. So from a personal standpoint, I'm going to say that we in academia, and especially at the Harvard T.H. Chan School of Public Health, have a special responsibility to do everything we can to support and enable and prepare those students who are coming to public health, especially now, to prepare them to be extraordinary leaders. Let me say why I say this. These students who are coming to public health today are coming to public health with their eyes wide open about the primacy and importance of public health, about the errors we have made, and the opportunities that they have to improve on those errors. They are running towards a crisis of epic proportions when you think about pandemics, climate change, antimicrobial resistance. They are coming to public health at a time where we need them the most. So that's where I start. Their North Star is the same as my North Star. I'm a first-generation college student. My family valued education beyond anything else, anything material, health and education. My parents made enormous sacrifices, and I know this is true for many of your viewers' parents as well, to afford me the best educational opportunity as possible. I studied molecular biology, basic science, but there was always a part of me that wanted to make the science more relevant to solving real problems. And public health was the place where I could marry basic science and social justice and action. And that's my North Star. And I'm inspired by that first and foremost. I'm where I am because of incredible women who never had the opportunity to lead. And I know I stand on their shoulders. So I want to use this opportunity to reflect and thank you for asking me that question, because every woman coming into public health or public service or even corporate world leadership have to live by one core principle. What brought you to service in the first place? And keep going back to that, because the challenges we face, especially in public health, which is humbling, are going to make you question the decision of joining public health. But if you go back to your North Star, why did I want to marry developmental genetics with social justice? I'm living that why every day as I advocate for partners that include scientists, politicians, and people in industry, as I train students who are either scientists or practitioners, that there is a space for them in this world where they can solve problems at a local, regional, and most importantly, global scale.
Wow, I don't know how to top that one, but I just thank you for those inspirational words. Because I think for programs like this, we started off very much as a local effort in terms of looking at COVID, and now that we've been able to kind of migrate into more of these global discussion or more of the macro discussion. And you have certainly been one of my number one gets, and I am so happy that this evening in Hong Kong, that we could have you join us. Because I think what you said really is very inspirational. And when I was younger, I think my family, first generation immigrant, education. But as we get older, I'm here with my elderly mother. The one thing I say to my colleague in the Asia side in Hong Kong, and I wonder where I got it from until recently, I heard it from Ronnie himself, our chairman, health and family first. So health and family is our areas, you know, they're part of who we are. They're in our DNA. So health and family. And I think in this current global pandemic, I think more than ever, I think we have to treasure that, our health and our family. And especially times this last couple of years, I know many of my friends and colleagues have not been able to see their family for 2 or 3 years because of this lack of traveling. And I've been very lucky, but I want to be able to be here to speak to you and really be inspired by you. And I want to thank you again, Dean Williams, for joining us this morning. And I look forward to future discussion and with you as this, whether it's global pandemic or public health issue, you know, as we kind of develop this series, but also for Asia Society Hong Kong. You've spoken for us before, pre-COVID, and I know when we are back to normal, when Hong Kong can host conferences and can host global gathering, that we will have an opportunity to welcome you back to Hong Kong in person, because we miss you there, and I know we would love to see you back in Hong Kong and continue to hear from you. So again, thank you for joining us this morning, and thank you, the audience, for being with us. We look forward to bringing you further episodes as this COVID situation evolves, so stay tuned. And again, thanks to all of you.
Thank you, Alice.
Bye-bye.